Rahim. My name is Dr. Kamran Shaikh. I work in the UK as a consultant general adult psychiatrist. However, the topic we are discussing today relates to child psychiatry, in which I have some experience in my core training, about 3 years experience. But I'm not an authority at that. So, if there is anything which is factually not correct, please refer to the books. And my today's sharing will be based on the books and also my experience in the past in child psychiatry, and especially dedicated experience in the field of autism for about 6 months. So, I'm especially thankful to my previous supervisors, Professor Rubina Aslam and Professor Nasir Said Khan, for providing me and allowing me this opportunity to teach the trainees in Pakistan from here. So, so basically, let's start the screen sharing. So, what is autism? What do you understand by autism? Anyone before we start?
Sir, I think autism is a pervasive
Yes.
developmental disorder in childhood, in which there are two things. There
Mhm.
one is repetitive restricted behavior, and other is communications. So these two things autism the spectrum
Yeah.
disorder.
Excellent. Okay. So you can see my first slide now, yeah?
Yes, sir.
Okay. So, so let's go with the etymology or the name. Where does the name start or takes its origin from? So the name autism actually came from the Swiss psychiatrist Eugene Bleuler when he was describing the negative symptoms of schizophrenia. I think when we were discussing schizophrenia and OSCEs, I mentioned that Bleuler said that social withdrawal, autoism, auto means self and ism means phenomenon. So self phenomenon. So the phenomenon of being on oneself, the phenomenon of social withdrawal, it is called autism by definition. And that was in 1912. But later on in 1943, Leo Kanner described a syndrome of kind of childhood autism, or 11 cases of what he termed as autistic disturbances of affective contact. So he did not even name it as autism, but he said autistic disturbances of affective contact. So the term was already in use by Eugene Bleuler for the negative symptoms, but he just kind of reintroduced in a different context. So in these cases, there was a congenital inability to relate to people in usual ways. Now, initially, it was like Kanner thought that kind of people have only social difficulty, but late and intellectually they are all right. But later on, the other researchers and psychiatrists, when they came, they uh, they found out that there is a comorbidity of uh, what we call as intellectual disability in autism, and it is a very strong comorbidity, so that 31% have intellectual disability. And even if they are and if we take the mild kind of very borderline intelligence into account, then 23% have IQs in the borderline below average range. So there is a very huge overlap with intellectual disability. So the terminology autistic spectrum disorder is the latest terminology. In ICD-10, it is used as childhood autism, Asperger's syndrome, and autistic spectrum disorder, NOS, not otherwise specified. In DSM-5, it is pervasive developmental disorders, which one subtype will be autism, the second subtype will be Asperger's syndrome. That's DSM-4 I'm talking about now. So pervasive developmental disorder, subtypes are autism, Asperger's syndrome, and PDD-NOS, pervasive developmental disorder, not otherwise specified. So ICD-10, they call it unspecified, while DSM-5, 4 and 5, they say NOS, not otherwise specified. So that's where the terminology is. So, but the latest term is autistic spectrum disorder. That is from the DSM-5, and I hope that ICD-11 may also follow that. And the other terms are becoming obsolete, such as childhood autism, Asperger's syndrome, and PDDs. Now, the epidemiology. So in 1966, so everything, like most of the things are coming from the Kaplan and Sadok comprehensive textbook of psychiatry. So, so in 1966, prevalence rate of 4.5 in 10,000 was observed. And then some other studies said that 9.5 in 10,000. And if we convert that into round figures, becomes in 10 in 10,000. Or if we uh, further simplify it, becomes 1 in 1,000. So that is according to some studies. So, and then so 1 in 1,000 or 1 in varying between the studies. And then a larger number exhibiting some features of the condition. So there are some features of the condition in a lot of individuals who cannot be diagnosed with the autistic spectrum disorder, or even they may not even meet the criteria of ASD, not otherwise specified, or PDD-NOS. So, but there are traits. So every 1 in 150 people have some autistic traits. Male to female ratio. Now, interestingly, when we go with the intellectual disability, male and female ratio is very close to each other, 1.5 to 1 in severely learning disabled population. But when the intelligence rises, and it's in direct proportion with the increasing intelligence, male to female ratio also increases. So normally with mild to moderate LD, it is male to female ratio is 4:1. High functioning autism, it is male to female ratio is 6:1. And there are previous studies which also say that 9:1. And the kind of MCQs can be made out of uh, these statistics. So diagnostic criteria and types. So I will go only with the DSM-5 today, and I will tell you where the DSM-5 differs with the ICD-10. And in the whole child psychiatry, DSM-5 is the gold standard. So child psychiatry, whether it's Europe, Ireland, England, uh, or UK or USA, Canada, everywhere in the world, in child psychiatry, DSM-5 classification is followed mostly. So let's stick to that. So in DSM-5, the previously used, like in DSM-4, the triad of impairments, there was a triad of impairments. As Rizwan mentioned before the session, that there are two things, uh, like there are two things, social and communication thing and restrictive behavior. But when we go to the like past classifications, whether it is ICD-10 or DSM-4, there was a triad, and the triad was number one, difficulties in social interaction; number two, communication difficulties; number three, repetitive and restricted interests. So now they have collapsed that into two domains. A, social communication. So they have combined the social and communication bit. And B, restricted and repetitive behaviors. Now, anybody answer me, what are the two main components of ADHD, attention deficit hyperactivity disorder? In terms of three and in terms of two, tell me both or at least one.
सर उसमें जो है इन इनअटेंशन होता है और हाइपर एक्टिविटी, ये तो नाम से जो है उसमें
Excellent. So these are the two now. But previously, that was also divided into three. Hyperactivity was divided into hyperactivity and impulsivity. And the third was inattention. So in DSM-5, they combined hyperactivity and impulsivity into one spectrum and attention deficit into other spectrum. In the same way, they combined here social communication and restricted and repetitive social, like social difficulties and communication. They combine together. And the second domain is restricted and repetitive behaviors. So you should know these two core symptoms. And then what they say is that in the social communications, there are three subheadings. All three should be fulfilled. In the restrictive and repetitive behaviors, there will be four kind of symptoms. At least two should be present. So in social communication, all three, and restricted and repetitive behaviors, at least two out of four. So the category B, restricted and repetitive behaviors, also incorporates the sensory difficulties, over or under sensitivity to the environment. Previously, they said that miscellaneous symptoms, but now they say that this is related to a change, restrictive perception of senses. So it is quite restrictive, and any change in the kind of sensory modality is a change in environment. So, and it's a kind of restrictive interest or restrictive activity in itself. Or so hypo, undersensitivity or oversensitivity, they brought it into B, into the criteria B. So let's say in the DSM-5 autistic spectrum disorder diagnostic criteria. So A is persistent deficits in social communication and social interaction across multiple contexts, such as manifested by the following currently or by history. So number one is deficits in social emotional reciprocity. Means that if you are saying something to these individuals, they are not reciprocating in appropriately. For example, if you are congratulating or saying greetings to them, their response will be either there will be no response, or if they learn to say some response, the response may be a little bit odd in their tone of voice, volume, or anything. So ranging, for example, from abnormal social approach or and failure of a normal back and forth conversation, to reduce sharing of interests, emotions, or affect. Secondly, they don't share their interests with others or their emotions, their play, whatever they are playing, they don't want to play with other people, their mood, they will not share. Failure to initiate or respond to social interactions. So if people are playing, the children are playing, even if they are trying to involve the autistic children, they will not respond, or they will refuse at times. If they have, at least if they have kind of good communication, they will refuse. So, and again, their refusal will be a little bit odd. I don't want to play. That's it. So they will say very bluntly. And then the second thing, which should be their deficits in non-verbal communicative behaviors. For example, uh, poorly integrated verbal and non-verbal communication. So their expression, their facial expression, use of hand gestures. Either there will be no use of hand gestures, or it could be a little bit exaggerated or unusual in nature. Eye contact will be quite unusual and reduced. And what you see in that their eye contact is that they will see past the point. They will not look into your eyes. They may observe other people's, for example, lips or nose or forehead or their hairstyle or the furrows on their head. So they will uh, notice other things, but not have a quality eye contact. And sometimes they do maintain a quality eye contact, but if they look directly into the eyes of other people, what happens is they lose their attention and concentration. They cannot focus into what's being said to them. So in order to perceive from other person, they have to look elsewhere, maybe somewhere else, or maybe into the face of the person, but not exactly into eyes. And then they can perceive and they can retain and they can kind of consolidate information coming from. So their frequency is a bit different than other people. With the eye contact, they won't be able. Otherwise, they will start kind of noticing the eyes or other things, and they will get distracted if they look into eyes. Now, the body language is a bit different, and total lack of facial expression could be there, or there could be abnormal facial expression and non-verbal communication. So it could go from one extreme to other, but there will be no appropriateness, either no facial expression or extremely reactive facial expression. There will be no in between or moderacy in that. So that's the second one. So the first one is reciprocity, and the second is the social, like the facial expression and use of gestures, eye contact, etc. And the third is the real kind of the social bit. So they have deficits in the theory of mind, deficits in developing, maintaining, and understanding relationships, ranging from, for example, from difficulties in adjusting behavior to suit various social contexts. Like if they are saying something, if they have learned something in one environment, they will do the same thing in the other environment, while the demands and the requirements and the taqaza of the other environment may be totally different. So that's what happens, is that they will apply the same rules in all the settings if they learn something. So they can't tailor their things in from scenario to scenario, from place to place, or situation to situation. So difficulties, and they have difficulties in sharing imaginative play or in making friends, to absence of interest in peers. So they will either take no interest, or they may have difficulty in making friends, and usually they will make friends with the people who will be friend with them, because they won't be able to initiate friendships with other people. So by chance, if they get some uh, friendships, they will be able to carry on with and their friends will be having kind of people with kind of same kind of interaction and same kind of personality. They will become friends with those, otherwise not everyone, because they will be a little bit different to them. So this is the criteria. There are other symptoms which will, when we discuss the course of the condition, then we'll come to the other symptoms. So all three should be there, that reciprocity, non-verbal communicative behavior difficulty, and deficits in developing and maintaining and understanding relationships. Now the B has four subtypes of symptoms, and you have to have two at least those, and they are restrictive repetitive patterns of behavior, interests, or activities. And the fourth is motor activities as well. So, so falling currently or by history. So, and the list is not exhaustive, so it could be anything, any interest. They are giving examples here, the DSM-5, but the examples may range from culture to culture, may vary from culture to culture and setting to setting. Is a repetitive motor movements, use of objects of speech such as motor stereotypies, lining up twice, flipping objects, echolalia means mimicking the examiner, or idiosyncratic phrases. That's the first thing here. Motor, and more more prominent is the learning disability, the more it is motor. So the rocking, flapping, all these things you see more in the learning disabled population, and with more severe motor stereotypies in the people with moderate or severe learning disability. It will be more motor, because they don't know how to do things, and they don't know how to say things, and they are usually non-verbal, so their stereotypies will be motor, rocking, flapping, clapping, things like that. But when the intelligence goes higher, it goes on to routines. So with the people with mild learning disability or no learning disability, with average or above average IQ, they can have inflexible adherence to routines or ritualized patterns or verbal or non-verbal behavior. For example, small changes will upset them. So extreme distress at small changes. For example, there is a summer vacation, or for example, there is a school break due to coronavirus, and they like their school in case. They will be they will get extremely upset why their school is closed due to the coronavirus, and when will the school reopen, and they want to go to school. Or if, for example, if they were having a swimming during the summer in their school or elsewhere, and in the winter the swimming sessions are closed, they will get upset why. Or if they're wearing shorts in the summer and they are not able to wear shorts in winter, they will get upset. So difficulties with transitions, that's what I was describing. And rigid thinking patterns. So if I have to go, I have to sit in the same seat, I have to go through the same route, otherwise it will be difficult. Greeting rituals will be kind of sameness, so the same thing they would like to say again and again. And they are very picky and choosy in their food, so they want to eat the same food every day, and if there is a change in the food they will not like it. The third thing is highly restricted interests in abnormal in interest intensity or focus, uh, and preoccupation with unusual objects, circumscribed or perseverative interest. So, for example, their interest may be the most common. Can somebody tell me what is the most common interest of autistic children nowadays in this technology era?
Sir, I think mobile use या devices use करना.
Exactly. So electronics, they are much fixated with the electronics, but the old books, old classifications, they will tell you other things, storybooks, encyclopedia, etc. Because these things date back to the 70s and 80s when electronics were not available. But even in those times, if there was an Atari game or if there was a Nintendo single video game, they will be on that game all the day, all the time. So these are their electronics is the most commonly fixated interests. Then there will be unusual kind of interests they have, so, which can be appropriate and sometimes not quite appropriate. So, for example, collecting coins and stamps, and or sometimes, if it is inappropriate, collecting many things, holding on to things, and not throwing things. That will be quite a bit inappropriate. Or like I'm not judging anybody and I'm not diagnosing anybody, but I'm just giving an example, and I don't know whether that person had these traits or not. But if you remember the program Khabarnak, there was a used to be a guy Nasir Bhai. Do you remember that? Who knew about all the songs, their producers, their songwriter. He had
जी
all the
जी सर
information
वो
about
जो
who.
कोई भी गाना.
जी बताएं रिजवान.
जी जी जब बजता था तो वो उसकी ईयर ऑफ सॉन्ग रिटर्न किसने राइट की है सॉन्ग इसके बारे में बताते थे कि बताते हैं कि वो
बताते थे.
इस तरह जी
हाँ, तो अब वो फौत हो गए हैं, अल्लाह ताला गनी की रहमत करे. तो that was his specific interest, that he knew, he was an encyclopedia of that. And it is not inappropriate, but it's not usual. So it's a bit unusual to know everything about that. So these have they have not inappropriate, but they have unusual interests. So some people collect information on cars, which model of cars, and what types of cars
सर
they
आई हैव ए
know.
क्वेश्चन
Yes.
sir this kind of focus hyper focus is found I have read that it's found in ADHD population so how can we differentiate between these two kinds of and only depending upon the focus symptom.
No, okay. In ADHD, what happens is that there is a generalized lack of attention, but they can attend to, they can focus attention to the things they like. They're not overliking those things. They're not overvaluing those things. For
Yes,
example,
yes, yes.
a, a child with ADHD is there, and he is saying that he is very good at mathematics. Whenever that the teacher is teaching mathematics, or the maths period is there, maths teacher is coming, they are able to focus attention, and they are able to give attention as much as other students. So they are equal to other students in mathematics. But when it comes to Pakistan studies, for example, or geography or history, they would lose interest. They will not know. They will not like it at all. So what happens is, when the exam results comes, they score 100 by 100 in maths, while they will get 40% in social studies. So that's not their special interest, but that is their likeness. So that's only likeness. But here, the special interest, it will be an extreme likeness. So in ADHD,
Okay,
the
sir.
likeness will be not at extreme.
Okay, sir. Thank you so much, sir.
Okay, yeah. So then the fourth one is hypo or hyperactivity to sensory input. For example, these individuals do not, many of the autistic individuals do not feel pain. And it's very much like the loss of pain in the diabetic neuropathy, that they get injured. For example, sometimes diabetic neuropathic people, they get an injury and they don't know and they don't care because they're not having pain. So pain is a blessing of God in itself, because when it happens, you treat it. So sometimes these autistic children, in the same way, they don't feel the pain, and sometimes they get like, and they can't even describe what happened to them in the words. So sometimes there could be an injury to them. They might not know, nobody will know, and they might not feel the pain. And maybe fourth or fifth day, you notice a bruise on their head, or you may uh, observe something quite early as well. But they might not be able to. On the other hand, their sense will be quite heightened to some of the sounds they like, and they don't like. So the heightened sense of sensation will be the unliked sounds. For example, if there is a vacuum cleaner, they will not like these sounds, or a car horn, they will not like. So the traffic noise. But on the other hand, if they are playing their own songs they like, they will play in very loud volume, and they will not care for other people, that other people may also have sensory issues, and they will shout and scream at the same time, and they will not care for other people. So they have kind of low sensory threshold for the noises of vacuum cleaner and horns, but very high threshold for the noise they are producing or they like. So the music or their own shouting, screaming, they will do without realizing other people. And that's why one of the additional symptoms is a relative lack of empathy, which is actually the lack of theory of mind. So sometimes they are sensitive to the bright lights as well. Now, so out of these four symptoms, you have to have two. So motor stereotypy, or routines or interest stereotypy, and fixated interest, and sensory input, hypersensitivity or hyposensitivity to things. Not in allergic terms, but just psychologically describing. And then the other things in the criteria, symptoms must be present present in the early developmental period of time, but may not become fully manifest until the social demands are more kind of needed. So they can be masked by learning strategies in the later life. So, and that's why more you make them learn, they will be able to mask and they will do well in their life. So that's why learning is so important. And ICD-10, I remember, I think it says that usually before 3 years of age, the symptoms should arise. Some symptoms should be there. Now, symptoms. These symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. And these disturbances are not better explained by intellectual disability. So, not sometimes, the intellectual disability, learning disability in itself will give some of the symptoms, but they will be more of a comorbid with intellectual disability on its own. So, and they will not be the core symptoms of intellectual disability. And then individuals who have marked deficits in social communication, but whose symptoms do not otherwise meet the criteria, should be evaluated for social pragmatic communication disorder. Now, the PDD-NOS, I think they have kind of made the term obsolete, not otherwise specified, and they are trying to specify. The DSM-5 is trying to specify everything what they can. So what they have done is, if there are 3 symptoms here, for example, in the criteria A, social communication, there are all 3 symptoms in reciprocating and non-verbal communication and relationship forming and verbal communication. So if there are disturbances in social communication, but there is nothing in B, or only one thing in B, you need 2 for diagnosis of autistic spectrum disorder. So if there is only one out of these 4 or no out of these 4, then the diagnosis will be social communication disorder. Okay, so that's a new diagnostic category in DSM-5, or it's also called pragmatic communication disorder. So social pragmatic communication disorder, they will not have any unusual motor movements, they will not have any sensory sensitivities, they will not have any stereotype interests, they will not have any stereotype activities and mannerisms again and again. Only disturbance they will have is social communication, that how to communicate with people and how to make the relationships, and that will be called social pragmatic communication disorder, which is a differential diagnosis. Now the main differential diagnosis is this social communication disorder, because it fulfills the criteria, the A criteria, but not the B criteria. Okay, so specifiers. So now, instead of saying not otherwise specified, the DSM-5 tries to specify as much as they can, and then they go to the unspecified or NOS category. So with or without the previous term mental retardation or learning disability or intellectual disability or intellectual impairment, or with or without accompanying language impairment. So these 2 things you have to see along with autism. So that's why they were saying, they mention more of a non-verbal here, but not the verbal communication when we see here non-verbal, because they are taking language as a separate entities, language impairment. But there will be some language impairment in most of them. The more severe, the severest language impairment will be that being non-verbal, so being kind of, when we say that being mute, they are not able uh, to produce the words. They will use only unusual sounds, although they are not deaf from the ears, but they still can't speak. So the people with the profound learning disability and severe learning disability, while with the moderate learning disability, they may have some speech. So, so previously, now the difference, I'm telling you the definition of Asperger syndrome. In simpler terms, high functioning autism is called Asperger syndrome, high function autism. So, no intellectual impairment and no language impairment, that is Asperger syndrome. However, there is slight difference that some people do not have language impairment, but their language is delayed by a few years. So they are only called high functioning autism, but not Asperger. But I won't confuse you because this term is becoming now obsolete. So Asperger means it's not synonym with the high functioning autism, no intellectual impairment, no language impairment, and that is called Asperger. That doesn't mean that Asperger people will have no language phenotypes. They will have difficulties in the use of language, but it will be very subtle, very, very subtle. For example, acquiring a foreign accent or speaking in the same tone or excessive use of vocabulary, like being extra literary in their use of vocabulary. So these all things can be present in Asperger syndrome or high functioning autism. But you won't classify as an impairment because they are still fully able to communicate their needs to other people and to perceive the needs and communication from other people, although it's a bit unusual. Now, the other specifier is associated with a known medical or genetic condition. For example, Fragile X syndrome, Rett. So Rett syndrome was in the diagnostic criteria in ICD-10, but there are many other things which the ICD-10 did not include. So, so now they say that no, any medical condition you can add and you can just specify, or associated with other neurodevelopmental, mental, or behavioral disorder. So, kind of ADHD could be there as a neurodevelopmental, mental OCD can be comorbid, depression can be there, behavioral disorder, for example, temper tantrums, for example, even borderline personality disorders, believe me or not, they can be comorbid with the Asperger syndrome, and they're one of like very important comorbidities, and they're very difficult to treat when two of them are together because there is stubbornness in both, and if they want to take their life, they usually act on it. So remember, if there is a borderline personality disorder and you also suspect autism spectrum in them, then the risk is high. And as we discussed in the catatonia lecture, it can be present with or without catatonia, and usually the echolalia and the perseveration, these are the catatonic symptoms, or motor activities to and fro, they can be catatonic symptoms. So sometimes they may or sometimes they may not fulfill the criteria of catatonia, which is laid down in the code 293.89 or in ICD-10 F06.1. And then severity levels for autistic spectrum disorders. So level 3 like requiring very substantial support. So a person who is almost mute and they don't know how to make friends and they are on their own, they will need very high support from the community. Level 2 is requiring substantial support. So marked deficits in verbal and non-verbal social communication skills, but not as high as level 3. And there will be inflexibility of behavior in all almost. And then level one is just requiring some support. So without supports in place, deficits in social communication cause noticeable impairments. So they can survive without support, but they will struggle. So they will need some support. And that's from the Kaplan and Sadok. So now the etiology. So what is the etiology of the causes? Psychosocial theories. Earlier on, when Kanner started describing it, they were like started blaming the parents, cold parenting style. Parents are not warm enough. So they were called, the term they used, and I did not deliberately put it into my slide, is refrigerator mothers, which is absolutely false. And then the other term would be, for example, in schizophrenia, it will be schizophrenogenic mothers. So these things should not be there. So they should not be stigmatized. And in this case, the mothers are not at fault at all. Like in borderline personality disorder, for example, the parenting may be a bit at fault. But here in ADHD, it's not at fault. In ASD, it's not at fault. Maybe in conduct disorder, maybe in oppositional defiant disorder, there could be some deficit in parenting. In autism, for God, there's no deficit in parenting. It's purely biological. So biological theories, presence of epilepsy more in this population, that will indicate, yes, it's biological. Intellectual disability is there. It's not parenting, it is biological. Medical and genetic conditions are there. That is biological. Fragile X syndrome and other medical conditions. So genetic causes, 60% of monozygotic twins will share the diagnosis of autism. And if we just go with the relaxed definition of having some autistic traits or saying ASD not otherwise specified, 80 to 90% monozygotic twins will have concordance of some kind of autistic traits. So that's purely genetic. Close link with Fragile X syndrome and Fragile X mental retardation protein. And then there are de novo or fresh variations in the submicroscopic structures of chromosomes, also called copy number variations. Then tuberous sclerosis, neurofibromatosis, congenital rubella, they're all point towards genetic etiology. And then something which is not genetic but biological. So it is not genetic but still it is biological, can add to and can increase the likelihood of or worsen the already individuals at risk of developing this. For example, prenatal or perinatal or neonatal factors. So if the child becomes, for example, very severe meningitis or encephalitis in their first year, or the mother had a kind of significant injury, or she was taking teratogenic drugs, or using alcohol or drugs, or some medication. So in that case, the child was at risk of developing autism already, but these things will increase the likelihood of autism, and these things will worsen the pre-existing autism. So the autism will be more worse if these factors are added. So gene environment interaction. Neuroimaging and brain development, they also tell that there are some changes in the brain. For example, reduced hippocampus size, prefrontal cortex, cortical thinning. The anterior temporal lobe also showed significantly reduced surface area with age. So these are some structural changes which you can see. And so the brain regions of potential importance, amygdala, uh, and fusiform gyrus and posterior superior temporal sulcus, orbital prefrontal cortex, medial prefrontal cortex. So there are functional, at least some functional deficits in these areas in autism, if not structural, because all these things, emotional arousal, social reward, circuitry, face, person recognition, etc., all social cognition, emotional learning, interpreting nonverbal communication, all these things will be impaired in autism. So that means there are uh, deficits in these areas. And this table was taken from the Kaplan and Sadok comprehensive textbook of psychiatry. Neurochemistry, again, it's not very important, but when there are structural and functional changes, there there could be some hyperdopaminergic function of the brain, might explain overactivity and stereotypy. And that's why when you give, sometimes they worsen the stereotypy and they can induce the tics. And that's why you have to use sometimes clonidine or antipsychotics in these individuals rather than methylphenidate. Endogenous opioids may also explain some of these things. And oxytocin is also related with that. So the next one is immune theories of autism. Now, immune theory, in origin, it was that there could be an immune reaction to something in the mother's serum, and the maternal antibodies directed against the fetus may produce in utero. That, again, that's very poorly understood, but there could be something. And there is one thing which is not there, which is totally proven wrong, and that is MMR theory. That some of the researchers in the past, they suggested that MMR, giving MMR vaccine was related to autism and could have caused autism because they will form the antibodies and then those antibodies will damage the brains. That was later on proved wrong. And there was a big ethical dilemma because many children might have missed the MMR vaccines and may have developed measles, mumps, or rubella as a result. So that's why those researchers, they were kind of disqualified after this. So this MMR theory is totally wrong. Now, onset and course, and that's where our main discussion of today is. Some of the symptoms I've described in while describing the diagnostic criteria, and the other symptoms I will describe here, which don't appear in the criteria or which we haven't described so far. So usually parents will typically become concerned between the ages of 12 and 18 months if they are not in denial. And if they are in denial, then the grandparents or the phupis or khalas or chachis or mummies, they will notice something. कि बच्चा बोलता नहीं है, बच्चा देख नहीं रहा, not looking at us. What's wrong? So the your close relatives will focus your attention. आपकी तवज्जो मबजूल करवाएंगे इस जानिब. Should get him. So between 12 and 18 months, the first concern is raised by any of the family member or any of the relatives or family friends. The first concern is that the child is deaf, and believe me or not, the first contact, the first referral is to an ENT surgeon because they feel the child is deaf. And the reason for this deafness is they are hearing, but they are not listening. Or if they are listening, they are not responding. So, as if they are deaf. So, emotionally, they are deaf actually, but physiologically, they are not deaf. Their hearing is perfect unless proved otherwise, or unless there is a comorbid deafness, which is very uncommon in this population. So they are not listening to what you are saying, or if you are calling their name, for example, Atif, Atif, they are not listening. But the big differentiating factor here is put their favorite nursery rhymes on. They will start rocking and clapping and smiling, and they will show every response to their nursery rhymes. And if they have some speech, they will start singing those nursery rhymes, or at least a part of them. So that is the test which you can do in your clinics rather than referring them to the ENT. The child just show them a YouTube video and ask their mother which video they like, or otherwise any nursery rhyme video or any video they like. They will start kind of banging and rocking at those videos. The parents also note that the child may respond quite dramatically to sounds in the inanimate environment. So there is some response. And occasionally parents report that the child seemed to develop some language. Yes, that's another thing which is mentioned in the Kaplan Sodok, that the child is developing some language, but they lose. For example, the child started learning saying Abu, 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 look, look, look. And 6 months later, they lose this ability to say this. And then maybe 3 or 4 years later, or 6 years later, they will get all the language back if they are not non-verbal. But this is differential diagnosis will be childhood disintegrated disorder, which is mentioned in ICD-10. That will come in the kind of differential diagnosis, that in childhood disintegrative disorder, the disintegration will be very marked and in every domain. Here, the child only learned some babbling and some phrases, and all of a sudden they they unlearned those phrases in about a few months' time. So there is a slight unlearning, and that's typical of autism. So, and then some parents start blaming that our child was, and that's where the MMR theory also comes. Our child was learning how to babble, and after this MMR, they stopped speaking. But this will happen even if they are if they don't have MMR. It might happen that they will learn some babbling and they will lose it. Okay, so or if they do not lose it, it comes to a plateau and the further learning is lost for another few years. And then they will reach a plateau stage, either after some decline or just straight into a plateau. Impairment in social communication. So we've already discussed that what will be the social communication difficulties are there. So they will not play together. They will play on their own. So they will play even solitary plays. Or if they are playing something with other people, it will be something online, electronically, where they don't have to make kind of physical contact with them, one-to-one, face-to-face contact with anyone. And then the next one is so the first year, what the parents notice is limited ability to anticipate being picked up. So if they are holding them into your goad or your lap, they will not anticipate, they will not show the response. Poor response to name and excessive mouthing. So they will say anything comes to their mouth, ba, 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 ba. And it may be even more than other children, but that will not be social, unfortunately. And they will not look at objects held by others. They will sometimes they like hugs and sometimes they do not like hugs and kisses. And low frequency of looking at people, no eye contact, no interactive games, little affection towards family, content to be alone. So if your child is sitting in room and you are sitting in another room for the whole day, they will not bother. They will not even, the thing which is really bothering is that sometimes they do not have stranger anxiety. And sometimes if they are lost in a bazaar or in a market, they will not tell anybody. They will show no distress for quite some time unless they grow older, until they grow older. So you have to very closely supervise. And suddenly some of the passers-by will just recognize them and bring them to you, or you will hear an announcement, a child is found, not able to tell their name, not showing any response actually. So that can happen. They do not have stranger anxiety sometimes. That's the first year. And second year, abnormal eye contact, limited social referencing. If they want to say something, they will kind of hold your finger and take your finger to the desired object. They will drag you to the desired object. For example, if they want to drink water, they will hold your finger and grab you to the kitchen. Instead of saying mom, or instead of using their hand gesture that they are thirsty, they will just drag you to the kitchen. And if you still do not understand, they will find a glass and they will give you the glass, but they will not say anything from their hand expressions or their verbal, their language. So limited social referencing, limited interest in other children, no social smile, no shared enjoyment, limited facial expressions, and then at other level, it's low frequency of verbal or non-verbal communication, showing, pointing. They will not point to objects. They will not say, "Oh, look, that's Santa." They will not say anything. So they will not share what they are enjoying about. They will keep it to themselves. That's where the autoism comes from. And hand and finger mannerisms will be there, poor response to their names. And then the social interests may increase over time, but more impaired individuals will become avoidant or aloof from interaction, whereas the other highly intellectual individuals may develop some unusual ways of interaction with others, or sometimes they can learn adequately about social interaction, how to make and maintain. So there is often social interest, but the person has difficulty in managing the complexities of social interaction. This often leads to an unusual or eccentric appearing social style. And 30 to 40% of individuals with autism never use language or so they will stay mute for the most of their life, or they will only echo. For example, you ask them, "Aapka naam kya hai?" They will say, "Aapka naam kya hai?" They will say, if you say, Aap Yusuf ho, they will say, Aap Yusuf ho. So they will not say, I am Yusuf, मैं Yusuf हूँ. They will say, you are Yusuf. Are you Yusuf? They will say, are you Yusuf? They will repeat the same thing what you are saying. Delays in acquisition of language are the most frequent presenting complaints of parents. And sometimes what happens is that there is a delay in language learning, but there is no underlying IQ disturbance. And when they learn the language fully. In that case, you can say it high functioning autism, but not Asperger's. But as I said, for you, high functioning autism is Asperger. So sometimes the language is learned at the age of 6 or 7. They have the full language, while the other children may have language at 3 years of age. And in some highly functioning children, there is no delay of language, so they will be quite normal in attaining the language, although they may overlearn or they may learn the very high vocabulary from the very young age if they are very intelligent. Children with autism may not babble or may take the parent's hand, as I already mentioned. So their focus is not their parent, but their parent's hand. And sometimes, if their parent is going on to work, they will not miss their parent. That why are they going to work? Because they have no stranger anxiety. They want to be on their own. But what will bother them is where has the car gone? And why the car has gone and they are still at home. So they are more attached to the car, for example, an object rather than their parent. No apparent motivation to engage in communication or attempt to communicate in via non-verbal means. So first of all, there is no spontaneous conversation or communication, and even the reciprocal communication is markedly impaired. Any questions up till now?
No, sir, I think we're going quite smooth.
Okay. Are you understanding?
Yes, sir.
Okay, it's fine. Yeah. So now the next slide about the course is when they speak, they can echolalia, they can produce echolalia. So lack of pronoun reversal, as I said earlier, that आपका नाम क्या है, they will say आपका नाम क्या है. If you say,
Sir, I want to ask one thing that one of my very first cousins has got this disorder, and he never developed any language or even babbling. I mean, he's now 8 and a half, and he doesn't even say a word.
hmm,
So ऐसा भी
they,
होता है कि you don't develop language at all?
yes, if we go on to the other upper slides, in terms of communication, as many as 30 to 40% of individuals with autism never use language for communication, or 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 I mean even less than that. Let's say 10 or 20% will have no language at all, unfortunately. So that is directly, use of language is directly proportional with the intellectual function, with their IQ, intelligence quotient. So the child you are telling about may have moderate or severe learning disability. And it's like usually they should have learned something by the age 7. It is, it's 8.5. They may learn something in the coming years, or they may stay as kind of non-verbal. And I remember one individual which is coming to my mind now, that she is deaf, so deaf and dumb both, and she is autistic. So like she can communicate with just not comparable to the other deaf individuals. So she cannot even communicate the best way as other deaf, because she's autistic and deaf, and that's the kind of worst case scenario.
Right.
But the good thing is she is fully mobile. The bad thing is the more are the chances they will show tantrums. So the temper tantrums are in the people with Asperger's syndrome or hyperfunctioning autism, and over literal interpretation of utterance. For gura gira khujur mein atka, they will take it very literally. And they will say, oh, khujur, like the date you eat, and something going into the date. They will not take it in the full picture that date means that it's a date tree, date palm tree, and even that is symbolic. So it is difficult. They will take things very literally. And if you teach them any rule, they will take it for granted for every situation. For example, if you say that be quiet in that surrounding, and they will remain quiet even in all the surroundings, even if they are asked to speak, they will not speak because they will say, oh, I was asked to keep quiet. Why should I speak now? So they kind of strictly follow the instructions in an unusual way. Monotonous or robotic speech. So, like, my name is Atif, मेरा नाम आतिफ है. आप क्या कर रहे हैं? आप क्या कर रहे हैं? So they have a normal child will say, Uncle, आप क्या करते हैं? But they will say, आप क्या कर रहे हैं? Or they will say, आप क्या कर रहे हैं? Or they will acquire some other kind of accents. They will pick accents from other communities. Non-verbal behavior is very impaired. Talking at great length about the topics of interest to them, but not their conversational partner. For example, if their interest is different kind of windows in the which Microsoft released, so they will talk about the windows to everyone, to their grandparents, and even to the grandparent who is some of our grandparents may not like have the scientific learning at all. Some people are not literate, so they will talk about highly literate things or about technology to them. Everybody, they will not change their topic to politics or other things or religion or literature. So from meeting to meeting, they will have the same topic everywhere. Deficits in play, unusual patterns of symbolic and imaginative play. So they will line up the blocks or the toys, but they will not play with the toy, the toys. For example, if a doctor clinic kind of doctor box is there, so they will line up these stethoscope and then and then the thermometer and then the percussion hammer and overall or whatever it is in the box, they will line up each thing, and they will not play doctor with other children. Or if there are blocks, they will line up the blocks, or they make a tower of the blocks. If they are putting uh, blocks onto one over another, they will just make a simple tower, just a thin tower, but they will not make anything constructive. And and then the next thing is so restrictive activities and interests. So the first we were talking about their social communication. Now their restrictive activities, I said that computer and electronics is one. Now one, I was told by a parent that he was so worried, and his child had kind of moderate kind of learning disability as well. So he said to his father that he wanted the same car which his father had, 1985 and maybe sold in back in let's say 2000. After 15 years he sold back the car, but the child was only 7 or 8 years old, and he remembered that car, and he would say, no, I want the same car. Now that car must have been resold and resold, वो आगे से आगे बिकती गई, और उसके अब्बू को पता भी नहीं होगा कि वो कार अब कहाँ है, but the child is just insisting. The moon, for example. जिस तरह नासिर साहब वो समझा रहे थे कि क्या खेलन, वो क्या था बेनजीर, खेलन चांद, सर ने एक कहावत सी बोली थी, यू रिमेम्बर, खेडन को खेडन को मांगे चांद, समथिंग लाइक दैट. सो
Yes.
उसके बाद
I cannot.
अटेम्प्ट टू
I said I cannot
attempt.
recall it at you.
Okay, no problem. Yeah, yeah. So, attempt to alter the sequence of some activity which may lead to catastrophic distress on the part of the child. As I said, that if I have to play the same game, I have to play the same game. And if you change the game, if you change the channel, there will be a catastrophic reaction from them. So either they will show no distress or they will show a catastrophic extreme distress and engage in activities in very particular ways. So they have particular ways of doing things which is different to other people, and that's why they can get bullied in their school, because of their stereotyped ways of doing things. They're uh, and they being different from other children, so the other children start bullying them or teasing them, annoying them. So interested in repetitive activity, for example, collecting strings and using them for self-stimulation. Like as I said, that collecting stamps and coins will be much appropriate, but collecting strings will be a little bit inappropriate, quite unusual. Memorizing numbers, certain words, or repeating their phrases. Transitional objects. Do you know the transitional objects? Anybody knows what it is? Are you familiar with the concept? Okay,
Like
transition.
dolls या इस तरह की
बिल्कुल
चीजें.
डॉल्स, बिल्कुल डॉल्स,
जैसे.
टेडी बेयर्स,
Hmm.
तो बच्चे रात को अपने साथ रख के सोते हैं, स्पेशली जब माएँ उनको अपने से जुदा कर रही होती हैं. When the mothers are trying to separate them, they give them a doll or a teddy bear to sleep with. So usually they are very soft toys, but these autistic children will have something more kind of harder things. For example, carrying a portable video game with them at the time of sleep. Stereotype movements, as I said already, and spinning objects, they are very much. For example, spinning fan, table fan, ceiling fan, a washing machine. So or the wheels, or the toys with the wheels, they will notice the wheels spinning. They will not take interest in the function of the toy, that's a tractor. They would be fascinated with the wheel rotating on and on. Computers, iPads, mobile phones will be their restrictive interests, and then lack of other features, lack of emotional intelligence. So, what to say, what not to say. It's not that they are lacking empathy. Some of them may and will come to the autistic psychopathy, but usually they are very innocent. They don't lack empathy. They lack understanding how to express empathy, and they lack the emotional intelligence, they lack the theory of mind. Eye tracking dysfunction, as I said earlier, that they will look into your nose or lips, not into your eyes. Shouting and screaming, unusually, some people have unusually high IQ. Hyperlexia, so they may be extremely good at reading or extremely good at computer use or computer programming, or some people, as I said about Nasir Bhai, that I don't know if he had that or not, but he was extraordinarily good at the everything related to the film industry. So some people are very good at calculation, and they will tell you what is the multiplication of 1 2 3 4 into 4 5 6 7 8, and they will tell you within fractions of seconds. I don't know why, but they have so good mental mathematics. So that's and they are also called islands of ability, because there's all over there is a sea, there is an ocean of disability, and in that ocean there is an island of ability that can be a super ability. Even people with mild learning disability may have some islet of hyperability, superability. Getting trivial information, why, for example, they go into the trivial information, and the scientist, again, that is controversial whether he had or not, but the scientist, and you know who I'm talking about, he just he was looking at the tree fell, and he went on contemplating that why did the apple fall, and why did it not go upstairs, and he came up with the laws of motion and laws of gravity and gravitational force. Great scientist. And similarly, there's a joke about some person, that a person who was kind of having on a spectrum, that he was staring with जिसमें गांव में अगर आप जाएं पंजाब में, स्पेशली इन पंजाब, तो थापियां होती हैं, जो उसको गोबर की थापियां होती हैं, वो दीवारों के साथ चिपकी होती हैं। ये जस्ट लतीफा है, जोक है, कि एक साहब जो हैं वो देखे जा रहे हैं, थापियों को देखे जा रहे हैं, देखे जा रहे हैं। दूर से एक और साहब आए, उन्होंने कहा भाई क्या, ये क्या, आप क्यों देखे जा रहे हो? कहता है भाई मैं सो इतनी ऊपर चढ़ी कैसे होगी? So that's but there is some abnormality in their thinking. Imaginary friends, that's another thing.
वैलिड है सर,
हम्म
क्वेश्चन तो उनका भी वैलिड है सर।
बिल्कुल वैलिड है। So, but the normal understanding will it be that it's human made. Humans put that dung on the walls. So imaginary friends, that's another thing very common in them. So they will like call their imaginary friends all day, rather than talking to the real persons about real things. They will talk to their imaginary friends about imaginary things. For example, Yusuf, मैं बाजार जा रहा हूँ. Yusuf, now I'm going to eat my dinner. Yusuf, okay, Yusuf, I'm going. Rather than, and there is nobody called Yusuf in their household, but they will refer to Yusuf rather than their own real brothers, Ibrahim, Ismail, and Atif. They will call Yusuf rather than them. And motor and sensory issues, we have touched with them. Vacuum cleaner sounds. Clumsiness, coordination disorder, that's a comorbidity in them, that they are not so good at riding the bicycle, or if they are playing football, they might not know how to kick a ball, or how to give a pass, or how to receive a pass. And sometimes, due to the lack of theory of mind, they can, some children may score into their own goals, and then getting bullied by the whole team later on for this foolishness, because they don't understand that the goal was the opposite goal which they had to score, not this one. So and odd way of walking and running will be there, and and we have touched about the hyposensitivity and hypersensitivity. Lack of emotional intelligence, eye tracking dysfunction. So we have discussed all of that. Now the unusual facial expression, physical characteristic, because of their patterns of learning, like even though their facial expressions were normal at birth, but they may develop because of their stereotypies and their behavioral patterns or unusual smiles. So they have unusual facial expressions at times, or unusual smile at their face all the times. Macrocephaly, yes, some children have larger than other people, larger skulls than other people. Hypertrichosis sometimes, not written in books, but I have observed children like increased hair, increased presence of hair, unusual smile, clumsiness, unusual behaviors may impact on physical appearance. That's what the Kaplan textbook says. And now, neuroimaging, it's not routinely. There is no fun, or there's like no need of getting neuroimaging for these children, because that is only of research purposes. If there is a frontal thinning, what will you do? You can't do anything, and that's not diagnostic. So, and that will cost a lot of money either to the state, if the state is paying, or to the individuals. Don't go for any imaging. Therefore, uh, for learning or research purposes. Similarly, hearing tested. Yeah, that's fine if you are really concerned, or for the sake of for your satisfaction, you can have hearing test. But I would recommend to do that test first at home and see whether they take interest in their rhymes or they repeat their rhymes or not. But otherwise, hearing test can be done. EEG, again, not very beneficial in diagnosis, so why to go? But sometimes multifocal spike activity and mixed discharge uh, can be seen in EEG. Course of prognosis, autism. So now we come to the prognosis. Autism is generally a lifelong disability. It does not get corrected. So if you are telling the parents, you can say yes, they can learn a lot of things in in their life, but they will not be back to normal. They will still have some difficulties for their life. So, and more there is a intellectual deficit or intellectual disability, more pronounced it is, more difficult it is to provide the learning to them, and more the poorer is the prognosis. And so the very high functioning children will become even the greatest scientists. And I know even in the present era, some of the big names, it is said about them, and I won't name because it's not ethical. So it's said that they might be on spectrum, but they are billionaires. And there might have been greater scientists, many of the greater scientists, in retrospect, it's said about them that they were high functioning autism, or having high functioning autism. So the aim of your treatment is to have some learning, social relatedness and communication, and some self-help skills to an adaptive degree, and gain in the social compliance. Sometimes you can treat the comorbid temper tantrums, challenging behavior, depression, anxiety, or psychosis. They are also at risk of getting teased, annoyed, or bullied by their peers, by their class fellows. And sometimes, remember, they can be bullies themselves. They can, because they don't have a theory of mind and they don't know how to enjoy in social situations. So their only enjoyment, their only social enjoyment may be to tease others. And that's the reality. I've seen many children whose siblings are annoyed of them, that they never talk to them, but when they talk, they just annoy them. And they know the weaknesses of others, and they just exploit the weaknesses with their innocent mind. They're very innocent inside. So differential diagnosis and comorbidities, deafness, we said receptive or expressive language disorder. That's another query of the parents. Has my children only got language disorder? If they had language disorder, they will, at least if they're expressive language disorder, they should look at you. They should use some gesture language. Like I know one person in our extended family. He was like his Nana Jan was deaf and dumb, but all other members were speaking. And the first language he learned was the sign language. And then a year later, he developed the Urdu language and English language as well. And now he is a topper. He's topping in his metric and FSC, and so he's so intelligent. So it was just a by chance that he learned from his grandfather the sign language first, because he loved him the most. So sometimes expressive language disorder, and then I already said social communication disorder if there are no stereotypies. Then other comorbidities: intellectual disability, ADHD, temper tantrums, as I said, autistic psychopathy. That's a concept to know sometimes, and that's a whole domain that exists in the UK. That some people who commit crime, they are on autistic spectrum disorder. That means that they don't have theory of mind, and they lack empathy as well, and they have sociopathic tendencies. So then you have to do from case to case, and they are liable and responsible for their for the comment the for the kind of crimes they commit. Emotionally unstable personality disorder, and they are at high risk. So just bear in mind that they can coexist. Depression, adjustment disorder, psychosis, Tourette syndrome, tics are very common in this population. OCD, obsessive compulsive disorder. So how would you differentiate between tics, stereotypes, and the compulsions in OCD? Anyone?
I mean, patient in compulsions, patient is compelled to do or perform a certain act, and he's aware of it, and he can even control it or delay it for some time. But tics or movements are such movements which are continuous, repetitive movements, mostly not in control. I think that's my definition.
Okay. I would say tics can be delayed. They can be partially controlled as well, like
Oh,
compulsions. And in the stereotypies uh, of the stereotypies of the autistic spectrum disorder and tics, they are almost very similar. So they can also be delayed, and in some environments, an autistic individual or a person with the Tourette syndrome might not discharge their tics. What is the other difference? Rizwan, do you know anything? Just unmute and say if you know or do not know. Is Rizwan there?
जी जी सर इतना मुझे इसका आइडिया नहीं है वैसे.
Okay, the differentiating point is,
हेलो.
yes, yes, मैंने सुन लिया भाई आपकी बात. तो इसमें जो differentiating point होगा, that's people with Tourette syndrome or autistic stereotypies, they will not be distressed by their movements. They will enjoy their routines, they will enjoy their movements, they will enjoy whatever they are doing. And sometimes I say to the parents, let them do. If they are enjoying, you also start enjoying. Why are you getting distressed as a parent when the child is not distressed? So sometimes we have to say that to the parents. But in OCD, in obsessive compulsive disorder, they are distressed by their compulsions, and they try to resist them, and they get more distressed. So that is the differentiating point. If they are getting more distress, that is OCD, and that's where you start treating them. So there the same stereotypies may become obsessions and compulsions, or they may get additional obsession and compulsions that can happen as a comorbidity in children with autism. The next is the rating scale. So I will just name and I will tell you which I have used. So ABC, CARS 2, MCHAT. I think MCHAT is for toddlers. So I might have used for screening at some point. CSBS, ASQ, AQ, which is autism quotient, CAST, ASDS, I got, which is Asperger Syndrome Diagnostic Scale, based on Gilbert's criteria. Or ASDI, Asperger Syndrome Diagnostic Inventory, actually, that is the ASDI, and I got training into that. That's where it's Gilbert is mentioned in ASDI, but not in ASDS. And GADS, SRS, ADI. So the upper ones are mainly screening purposes. The lower you go, they are more diagnostic. So they are, and that's why you see uses screening, 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 and diagnostic, diagnostic, diagnostic. Uh, so the ADI, autism diagnosis interview, diagnostic interview, that is a diagnostic and that is used. DISCO is diagnostic, but they are very expensive tests. So DISCO diagnostic interview, it stands for, and ADOS. So ADI and DISCO, they are both, I think they are both interview. If you see interview and clinician rated. So in interview, the clinician is interviewing the parents in both DISCO and ADI and not observing the child. In ADOS, it is a semi-structured interactive session. You are observing the child directly, and there is a bucket. इतनी बड़ी सारी बाल्टी होती है, I would say जितना बड़ा एक ड्रम होता है ना, उतना उतनी बड़ी एक बाल्टी, जिसमें कम से कम 100 लीटर की बाल्टी, 100 लीटर बकेट full of toys, papers, pens, radio, and different things. And it's very expensive. At least that will cost kind of 2 to 3 lakh rupees, or even more than that. I don't know what's its current price. So you start playing with the child uh, with those toys in a structured way as mentioned in their manual, and you start scoring. For example, if there's a glass of water, or if there is a glass, you ask them to drink water and to put the water for them, and then serve to you. So you score for that, whether the child is drinking water from it, and whether the child is sharing the water with you, or whether the child is giving the water to you, and similarly other things. So you just focus at their shared enjoyments. And then there's a questionnaire. You play with the child and you score the questionnaire, and there are 2 or 3 people. One is usually scoring, one is playing, and one is observing. So 4 people may be in the room. That is ADOS. Other instruments which are usually screening, but they are rated as diagnostic. Like here, ASDI, it says Asperger Syndrome Diagnostic Interview, but generally the authors say that it is for screening. And when we make diagnosis difficult, then we have to buy these very very expensive tools. So if we don't have, then we might have to use those screening instruments as diagnostic, and based your clinical judgment based on the DSM-5 criteria. If the criteria are fulfilled, then the diagnosis is clinical. So you can help with those. But ideally, in ideal environment, especially in the Western world, UK, US, and Ireland, you have to do one of these three: ADI, DISCO, or ADOS, for either high functioning or low functioning autism. In other words, if you don't have uh, these expensive things, you can make use of these screening instruments and use your own clinical judgment and use the criteria laid by DSM-5, and that will be sufficient for diagnosis. So similarly, Ritvo Autism and Asperger's Diagnostic Scale (RADS), they say it is diagnostic, but I think people will differ and they will say it is screening. So that's a kind of self-rating scale for adult Asperger syndrome or adult autism. Australian scale for Asperger syndrome, that's also another screening instrument. And what I sometimes do is that I go with the DSM-5 criteria, I take a full collateral history, and then I do the Australian scale of Asperger syndrome and ASDI, which is actually diagnostic in its name. And then very carefully I might give diagnosis to some people in which it is not possible to carry out the ADOS. Otherwise, ideally, you should do ADOS in everybody you can, or otherwise as a second line ADI or DISCO. So these are just the abbreviations: ADOS, ABC, ASQ, Autism Screening Questionnaire. Diagnostic methods, so detailed history, including developmental and family history. As I said earlier, whenever you are taking history of any child in child psychiatry station, three things are must. In collateral history, you must always take developmental and family history. And in one-to-one child history, you always say that everything is secret or confidential. But if you are at risk, I have to break that. Direct observation is the other word used in child psychiatry for mental state examination, because you mostly observe and you seldom get any phenomenology. So most of the things are based on your appearance and behavior and speech. Rating scales with parents, with child, with or adult individual, home and school observation, use of videotapes, and if it also may help the if the is asked to recall the child at a certain particular dates. For example, if the parents cannot recall, you may ask that how was the time when he was 3 years old, or when you moved the house, or when he started going to school, for example, or third birthday. No curative treatment is there. So treatment is only for associated, but you can modify the the core symptoms. The higher the intelligence is, more you are able to modify, but you can't cure them. You can't change an individual born with autism. Yes, you can teach them, you can learn them to modify, and if they are intelligent enough, they can to some extent. Social skills training and psychological management of their temper tantrums, coordination issues, physiotherapy, sports therapy, and occupational therapy. So speech and language therapy, they can all help, but they will not be curative. And then you measure the profile of strengths and needs, and you tailor the individual treatment according to the needs of the child. Vocational training could be there, independent living skills, and treatment depends on the level of intelligence and presence of comorbidities, uh, mainly. And stem cell therapy is one thing which we hear, but it's not in the books, and uh, and it's not something promising. There is no evidence that it works. It's still in the early stages of research, and whether it can cure or it can treat the core symptom, it won't be able to cure because the symptoms will still remain there. But whether it will be able to modify some core symptoms or not, we don't know. Stem cell therapy means that taking the stem cell from a sibling who is born before or after the child, and putting them in the refrigerator for some time and using those later on for the treatment of their sibling. but we don't know what will be the complications of everything. So, uh, and then special schooling. So that's what which is happening in the private sector in Pakistan, that special schools are there, or sometimes in the UK and Ireland, special classes in the mainstream schools, or sometimes in the mainstream class there is a special needs assistant, whether in the special classes everyone will have, or some children will have in the mainstream class. So if they are intelligent enough, they're only having Asperger, then they may go to the mainstream class, but they have a special teacher which will be sitting with them. And the drawback is that they will become more prominent among other children. The other children will know that this child has a special need. But the good thing is that the teacher will get them focused. That happens with the children with ADHD as well. So special tutor sitting with them. Anti-bullying approaches, so they should be protected from bullying. Picture exchange communication system, you show them pictures in stepwise. For example, uh, there are 10 pictures about toothbrushing. So you, in the first picture, you make that open the door of the toilet, and then the second picture you show the toothpaste and then toothbrush, and then in the third picture you the child takes toothbrush in their hands and then picks the toothpaste, and so on. So you break the task into chunks, and then you communicate with the different series of pictures. And it is very helpful in non-verbal children initially, but when they get the language, then you don't need it anymore. Stepwise learning, and then ABA, applied behavior analysis. What caused the child to have to show the tantrum, and what was the tantrum, and how it was kind of resolved in the end. So antecedent behavior consequence, or eidetic imagery therapy, which is not mentioned in the books, but Dr. Akhtar Ali Sayed, getting his PhD, may have completed by now. So he's a Pakistani psychologist, and he introduced. His wife is also psychologist. They're used to be in Pakistan, Punjab University. Now he's in Ireland, in Waterford. So he has introduced eidetic model of growth, or eidetic imagery therapy. You show the pictures from their past and then treat their kind of behavioral symptoms by individual psychotherapy, CBT for depression, anxiety, parental training. Although the parents are not at fault, but the parents need to learn how to cope and deal with children. They need to be psychoeducated, and for their psychoeducation, there are parental training programs to make them cope and deal and learn how to deal with their children in a positive and healthy way and in a therapeutic way. Uh, Pharmacology, no treatment for core symptoms. Antipsychotics for temper tantrums. If there are behavioral approaches have failed, try behavioral approaches and try the parental training, because sometimes, although in producing autism, it's not parents' fault at all, but sometimes they don't know how to deal with their temper tantrums. So if you train them, it is better than to give the antipsychotic. And if you end up in as a last resort, use extremely low dose of medications. For example, 2 to 3 milligrams per day of aripiprazole in syrup form, or 1.25 milligrams per, actually, uh, I think it's 0. I'm just editing it, it's wrong. 0.125 milligrams per day of risperidone per day, or haloperidol, even as small as the smallest dose you can imagine, 0.25 milligram per day. So, and you do also abnormal involuntary movement scale, because most likely they will get their tics will get worsened, uh, like the tardive dyskinesia in elderly. And ECG is a must, and also metabolic syndrome is so common. Even the 2 milligrams of aripiprazole or 0.125 of risperidone will blow these children up. So do their all the metabolic screen, HbA1c and glucose and everything. And then the second last slide. Yeah, clonidine. If there is a tic disorder or ADHD, you can give clonidine. Generally, it's given by neurologists or pediatricians because it lowers the blood pressure. So psychiatrists usually avoid giving it. Stimulants you can give, or atomoxetine you can give for ADHD children, or antidepressants for depression or anxiety, or OCD, you can treat them with antidepressant. Fluoxetine, again, when I was training, it was 2 milligrams per day, which is 0.5 ml per day, as low as it can be. So while in adults you can use a kind of 20 milligrams, so it is 1/10 of the adult dose. Because sometimes you have to give it to very small children, and try not to give anything to small children, but sometimes as a last resort you have to. So the references for today: Kaplan and Sadok, comprehensive. There is scientific literature I learned, and that's why this lecture is also quite comprehensive, because I followed that book. And DSM-5, and further reading, you can use the New Oxford Textbook of Psychiatry, Maudsley Prescribing Guidelines. Thanks for listening, and any questions?
No, sir. Thank you, sir. I think it was very extensive and elaborate. Thank you for your time
Mm.
and thank you for this presentation.
Anybody else, any questions?
Kamran, Dr. Inam here.
Sir,
Just want
Dr.
to
Inam,
know.
we have the privilege of having a child psychiatrist, and if I was wrong anywhere, if you want to correct anything, please do so, sir.
No, no, absolutely not. Like, it was always a pleasure to listen to you because it's, no matter how much I know, I always learn something when I listen
Yes,
to
sir.
you. Just wanted to know in terms of ADHD, you mentioned about atomoxetine. What about like other stimulants? Would you not give other stimulant like Ritalin, like
Yeah.
methylphenidate um, and like, amphetamine type drugs? Would you not consider that? Like you mentioned only atomoxetine.
Oh no, I don't think so.
No,
Maybe I
just
did.
in the end. You just in the end you said if there is ADHD,
Oh,
you give
okay.
atomoxetine.
No, no, no. That was just the time pressure. But otherwise, yeah. What I mean is that stimulants or atomoxetine. So yes,
Okay.
you can use Ritalin, methylphenidate, Concerta, or lisdexamfetamine, or sometimes atomoxetine. So yeah, you are
Okay.
absolutely right.
Yeah.
Like
That's
that's what its slide says: stimulants or atomoxetine for ADHD.
yeah.
Oh,
Yeah, just from my personal experience,
yes.
when you give stimulants to these children, particularly, obviously, the response is very variable. Like response is always different. As you said, these children could be very sensitive to medication. Particularly, methylphenidate response usually I don't find very good.
Mm-hmm.
So, but like I always find uh, less dexamphetamine or dexamphetamine
Yes.
better in children with ADHD with autism. So that's actually my personal experience, and it actually because this methylphenidate can take the emotions away sometimes. They can make them more suppressed. But the good thing with amphetamine type drug is that it doesn't like take the emotion that much away. So that's the positive side. So usually, like, when I try methylphenidate, because we used to go as a first line in children, we have to go
Yeah,
methylphenidate. But then, like, I keep in my mind that I expect the parents will say, well, my child is, he doesn't seem to be the same child he used to be. He's very depressed and suppressed, like, so um, then,
yeah.
like, in that
That's
case,
mm,
yeah. So I think you agree with that from your practice.
absolutely agreed. Yes, I fully agree that, yeah, and you are still working in child psychiatry, and you know much. It's absolutely right. Yes. And any
So,
other forms of practice, sir?
I would
Support of
like to ask one question from Dr. Nam, since you
yes,
told me that he's working
yes,
in the child psychiatry department. Those children who have autism spectrum disorders, any one of them, and they are diagnosed. So, what can we tell to? Is there any way which can halt the disease process? I mean, it's there. It's not going to, we cannot treat it, but worsening. Is there anything which can help the patients
Okay.
to prevent them from
Well,
worsening of the symptoms?
yeah. Well, I think Kamran actually covered it very well. This is a very good question, actually. Because every parent who comes to you, they will be expecting what you can do as a doctor. The problem with this disorder is this is actually narrow developmental disorder. That means this disorder is born and then developed with the child. So sometime, the child, in childhood, you may not see that many symptoms, but as the child grow, the symptom will grow with the child as well. So you will see many more symptoms. Okay, so what can you do? How can, like, you improve the child life, or how can you make the child better? I think it's a very
Yes.
comprehensive question, and we can talk and talk about it. But first of all, you have to find out what the child problem is. The most important thing here is that the child has sensory issues, so he can be disturbed. First of all, we should look at the symptoms, what we can, like, we can reduce his distress. Like, if, for example, in the medical setup, if someone has a pain, if someone has an illness, you reduce the pain first. So you give the person analgesic to reduce the pain, so you reduce the distress here. So if the child with autism comes to you, so you just first, before you do other thing, first reduce the distress. How you reduce the distress? If there are, like, if the environment is normal for you and me, may not be normal for the autistic child. For example, if he has problem with voices or noises, like, you make sure that the sensory issues are addressed. So first of all, you need to know the sensory issue, like the smell. How is the smell? The child may be, you know mm, he may be very sensitive to smell, so if he enters his house, he may become very disturbed. So you need to, like, that uh, uh, whatever is good for a general child is good for an autistic child as well. For example, they have problem with sleep, so you have to address that. You have to make sure that the child sleep well. That should be on the top of the list, because if the sleep is disturbed, the child is going to be very disturbed during daytime. So by improving the sleep, you naturally make the process better, so the child can, like, heal. There could be a lot of healing process in terms of the anxiety, in terms of the distress, in terms of the depression. So you can make the sleep better. Another thing is structure activities. These children, they are very they function only in a structured environment. Like, I actually joined a little bit later, but I think Kamran mentioned that. So structure is extremely important. They like structure, they like predictability. So if they are in the structured and predictable environment, they can function better. Another thing, for their sensory needs, sport activities can be very, very helpful. So that will address some of their self stimulation. For example, these children, they can self
But they
stimulate.
like to be engaged in plays. So how can you know? make them participate in some sort of sports activity?
Well, sports activities, not necessarily you tell them that they go and start football, or it could be as simple as going for a structure walk. Just, the parents can take
Right,
them for a, it could be yoga, it
right,
could be anything, it could be anything. But if sometimes they may be interested themselves in some sports activities, so that will actually address their self stimulation. They won't have to, like, when they flip their hands, they want to stimulate themselves, self normalization. And when they don't have, like, to like stimulation, so that can make them stress. So good structured sport activities, good sleep hygiene, and if you, like, deal with that, you are, like, dealing not only with their issue, but you are providing a nurturing, a better environment for their growth. So there is, like, hope. They may kind of, not necessarily get better in terms of environment, but then you can concentrate on their abilities. As Kamran mentioned, that these people have islands of abilities. So it's very important that you concentrate on that islands of abilities. And when you concentrate on their island of abilities, you can even approach their
right,
disability, these these abilities. Like, for example, if a child um, is, like, like aggressive in the house, so you ask the mother what are the things that he can do that he enjoys, and then, and from those activities, you engage the child, and maybe slowly, gradually, you take the child to the next step, to the activities initially the child doesn't want to do, but so I think, it's a very complex process, but whatever is good for any child could be good for a child with autism.
right.
But always, know what are the child's sensory issues. So
True.
apart from that, like, symptomatic treatment medications uh, could be good, but you should be very careful with medication, because the child could be very sensitive to medication as well. Yeah, so I
Mm-hmm.
hope I was able to answer your
Yes.
question to
Thank you
some
so much,
extent.
sir. Thank you.
No problem.
Thank you.
Thank you, sir. And you reminded me of 2012 when I worked in the autism service outpatients. And the things now I'm able to recall, sleep disturbance was so common in those children. And my
Uh,
consultant then, who's a very renowned name in Ireland, Professor Gallagher, I forgot her first name. So she used to say, first focus on the sleep hygiene and then come to the medication. So the sleep hygiene, for example, having good air, a good mattress, and normal heating, not too cold, not too hot, and having good ventilation, no noise in the house, no mobile phones after 8 or 9 o'clock, and then everybody is ready for sleep, and lights off, all these things, and no tea or coffee at the bedside. And even then, if the child is not able to sleep, then the lowest dose of melatonin, which is a hormone,
yes.
rather than giving them sleeping tablets, give them melatonin, which is more natural. So, and I remember most of the children in the autism spectrum disorder service, they were on melatonin. And when I moved to the child psychiatry, the general child psychiatry, very few children were on melatonin. So
Absolutely.
there's no.
I just want to mention, because you are all working in psychiatry, sleep is fundamental for children, because everything happens when the child is asleep. The growth, memory consolidation, uh, like, recovery from illness, dealing with all kind of illnesses. So sleep is actually a healing process. So if the child sleep well, you know that mean he will recover from a lot of problem. Now you mentioned about melatonin, so now, like, everything kind of lead to another thing. So absolutely, melatonin is the starting point. You give melatonin, and it actually varies. But the problem with melatonin is people get used to it very, very quickly. So tolerance is. So what you tell the parents that you take melatonin only the nights when the child is going to school, for example, the next day.
Oh, yes.
Take a break on the weekends. So
Good.
then the melatonin will continue to work. But if you give the melatonin continuously, after 2 weeks' time, the melatonin is not going to work. You can increase the dose up to 10 milligram, but if the melatonin was not working, you can obviously try promethazine. In Pakistan, they call it, I think, Phenergan, isn't it?
Phenergan, yes, yes.
Yeah, promethazine. So anti-allergic drug, you can give that. If like anti-allergic promethazine or melatonin, on its own doesn't work, you can combine, and usually in combination they work very, very well. But the aim should be that you make their sleep better, because no matter what you do with that child, if their sleep is disturbed, you will be wasting your and child's time. So that's actually the point to be noted. So just want to stress on this,
Yeah,
sleep should be put on the top of the list.
absolutely.
Yeah.
All
Thank
right.
you.
Hello,
Thank
Dr.
you.
Inam.
So we conclude here. Unless any other pearls of wisdom by Dr. Inam, otherwise we conclude. Sir, would you like to tell anything else to us? Okay, so that's the end of today, and thank you for your patience. It was more
Thank you,
than
sir.
2 hours, and I hope you
Thank
enjoyed and you learned from it. Okay, Allah Hafiz.
Yes.
Okay, Allah Hafiz,
Okay,
Asghar. Okay,
Allah
thank you.
Doctor.
Thank you for this.
Thank you, Dr. Kamran.
thank you, Dr. Inam.
Thank you.
Thank you.
Okay, Khuda Hafiz.